We are very excited about our meeting today. It has many items that you will be interested in. Specifically, this is Prematurity Awareness Month, and we are very pleased that we will have the March of Dimes with us. Both Lori Appelkamp and Erin Koppenbarger will be presenting in relation to the latest report card and what it shows about the U.S. and Oklahoma, as well as both good and not so good things going on in that regard, where we may be able to improve. But this month is a special month in really bringing awareness to prematurity and what we can do, what is being done, and what we can do to further decrease babies being born too soon and the complications that come from that. I know both we and our partners have several campaigns, including social media, going on right now to really use this month to further spread that awareness and preventing preterm birth. And yes, the March of Dimes actually launched its prematurity campaign in 2003. And it's going strong ever since. And they're a wonderful partner in fighting prematurity. Also, I want to state that this is American Diabetes Awareness Month, another thing that we work on with gestational diabetes, and Native American Heritage Month. So really want to recognize our Native American heritage here in Oklahoma. What a wonderful state where we have so many tribes represented that we are proud of and want to promote, especially during this month. And with that, I will be turning it over to our presenters of the day, and that is from the March of Dimes, Lori Appelkamp and Erin Koppenbarger. I'm turning it over to you, ladies.
Thank you. I appreciate it. Good morning, everyone. I hope everyone's having a good morning so far. So thank you guys for allowing us to do a presentation on the March of Dimes report card. I want to give you a little caveat in this information has not been actually released yet. It will be released tomorrow, the 16th officially. So I have to give a big shout out to Erin because she worked diligently trying to put this together so that we would have the information for you guys today. Once it's been released, then I will send over the actual report card to Kamisha for her to share with everyone. So again, too, since we just really have been reviewing this data just in the last day, if there are questions that we can't answer, please, Kamisha, if you wouldn't mind taking those questions down, and then we'll try to get an answer if we don't have the answers to those. So show us a little grace today because we're trying to provide this information that actually hasn't been released and doing our best job to try to share this information. And a lot of the data this year has been put together in a different way than in previous years with our report card. So there'll be some clarifications that I will make during the slides about how the data was put together and why, and the resources they used. And so Erin and I are going to kind of tag team this, and I'm going to start this off. So again, Lori Appelkamp with March of Dimes. I'm executive director here in Oklahoma. And the first thing I want to talk about is the preterm birth. I want to, of course, talk about tomorrow. Friday is Prematurity Awareness Month. When we talk about preterm birth, we know that a preterm birth is a live birth that occurs before 37 weeks complete gestation. So gestation can be based on a few different methods. One is by asking the patient when their last menstrual period was. Another's by obstetric estimate, which is what is used in our analysis and is aligned with our organization's way of measuring this preterm birth. I know I'm probably preaching to the choir here because everyone on this call probably is very familiar with this, but I just wanted to clarify what the information was and how it was derived. One second. All right. So really the more accurate, I guess, in the more widely accepted way of determining preterm birth is by the obstetric estimate. For many measures on this report card, including the preterm birth, we used birth data for all live births. We refer to this as natality data, and our perinatal data center requests and obtains this restricted access data from the National Center for Health Statistics at the CDC each September as soon as it's available. So that's how we get our data in regards to this information. Next slide is on the birth grade, the preterm birth grade. So you can see here, we assign the preterm birth grades based on the criteria on the right side. You can see wherever the rounded preterm birth rate falls determines which grade is assigned. And in 2019, the grades were expanded to include 3 levels for each letter grade, A minus. You can see here, the A and the F only have do not have 3 different grades. It's just those grades that are in between, as you can see here. And right now, currently, there is no state that has an A grade on preterm birth, which is very scary to think about, that we don't have a state that has an A in preterm birth right now. March of Dimes previously established a goal of 8.1 for preterm birth, and grade ranges are based on the standard deviations of the final 2014 preterm birth rate. Rates away from 8.1% goal, which was established in 2015. Right now, the preterm birth goals have changed over time, originally being set at 7.6% in 2008. I can actually remember when we started doing this and when we were starting to record this information when I started with the March of Dimes. And again, I reiterate, there is no state that has an A grade at this time. So if I go into the next slide, the preterm birth grade for Oklahoma is a D minus. So in 2021, the prematurity rate was 11.9%, giving us a grade of an F. And the 2022 data has improved slightly with a rate of 11.3, a 5% a 5% decrease, which makes 1 in every 8 babies, and moved us to a D minus. Oklahoma was one of 4 states that earned a D minus grade, including Texas, Nebraska, and Missouri. We continue to have higher preterm birth rates in the U.S., which has an overall rate of 10.4 and a grade of D plus. And then on the next slide, you'll see the preterm birth grade. You can just see the states and kind of where we are. I love that we're not in an F, but I want us to be an A, of course, but at least we're not in those red states that are on this map here, and that we are seeing some improvement. It's no surprise that the worst grades are seen in the southern region of the United States. On the next slide, the preterm birth grade, you can see that while Oklahoma has improved overall, we still have 3 of our most populated counties that have worsened. And Cleveland County, although the rate has improved, still stands at a grade F, which we just can't have that. We don't want to have that for our moms and babies in Oklahoma, of course. And you can find data on our perinatal data site that will actually have each county, but these are really the most populated here in Oklahoma that are shown in the slide. If you go on to the next slide, the preterm birth trend, this graph shows that the preterm birth rate for each year ranging from 2012 to 2022. The purple line indicates that the change during the dark purple period is statistically significant. The rate in Oklahoma improved from 11.9% last year, where the grade was an F, as we talked about. And in Oklahoma, the preterm birth rate has shown a shocking increase, 9.7% increase since 2014. On to the next slide, the preterm birth rate race by ethnicity. You can see here, unfortunately, this has not changed a great deal from last year. The birth rates by maternal and race ethnicity using bridged race categories, it's important to note that this is not the race of the baby. The Hispanic ethnicity category include all of those race categories, and these are a 3-year aggregate. We show 3 years of data because it increases the number of the race ethnicity categories that we are able to show due to suppression criteria. It also provides us a more stable estimate, especially in those states with the lower birth rates. So we have highlighted a statistic for the difference between the rate among the group with the highest preterm birth rate in Oklahoma compared to all other birthing people. That is the birth rate among babies born to Black birthing people is 1.5 times higher than the rate among all other babies. I also think it's really important to point out the disclaimer that we've added this year that the differences by race and ethnicity are not biological, but due to systemic racism. So again, these numbers are staggering here. We continue to have the highest birth rate among Black moms giving birth. And we really want to, of course, figure out how can we try to change those numbers and have those numbers go down. On to the next slide, the preterm birth by maternal factors. So I thought this was an interesting slide. It's a new one this year. This year they added this data that shows the rate of preterm birth rate among populations with specific maternal factors. And we display that prevalence of each factor among all the births. And below in the notes, you'll see the US number in those particular factors as well on each of these slides. The prevalence of smoking within the 3 months prior to pregnancy is 1.7 times higher than the national rate of 4.6%. And smoking impacts about 7.7% of all live births in Oklahoma. I'll also go ahead and highlight hypertension here. The rate of preterm birth rate among birthing people with pre-pregnancy hypertension is 22.2% in Oklahoma. And then you'll see in the US, it's 3.3%. That means that 1 in 5 birthing people with this factor will have a baby before 27 completed weeks of gestation.
Can I clarify something, Lori?
Yes, of course.
So the 3.3%, that is of all births in Oklahoma. So if you go down to the notes in the black, hypertension is in 23% of women, if that makes sense, before they're pregnant.
Okay, thank you for clarifying that, Erin. Thank you so much. Yeah. But you can see on here, I won't read all of these to you, but one, diabetes, 32.7%, where it's 1% in the US. So all of these statistics, I think this is really interesting, an interesting piece to add to the report card, kind of knowing some of the areas that we really need to focus on and see improvement, being specific on what we need to do. Sometimes I think as a whole, this information is like, okay, where do we start on trying to improve it? And at least we have some areas that we can see where can we make a difference in some of these and start making some change in particular areas. Okay, next slide. I'm going to talk about infant mortality. And sorry, let me go back to my note. Okay, so we're going to move on to this next indicator of infant mortality, or its death occurring among a child less than 1 year of age. We obtain this data from the birth data, which is linked to the infant death data, and the most recent year of data was from 2021. So I'll go on to the next slide, infant mortality. This trend is showing this graph is displayed from 2012 to 2021, the most recent year of data. Death data always lags about 1 year because of the way we have to wait until the end of the year for the age mark to be able to have that actual data. So you can see on here the report where we are at 7.1 in Oklahoma, and you can see last year we were at 5.9. So like preterm birth, any presence of purple line indicates a significant trend during that time period. And while this data does not indicate a significant trend, it is alarming rate to see that we went from 5.9 in 2020, actually, not last year, to a 7.1 in 2021, which is a 20% increase in infant death. So in 2021, just some numbers, 345 babies died before their first birthday, and the infant mortality rate was 7.1 deaths per 1,000 births, live births. And this is higher than the US rate of the 5.4 and worse than 45 of the 52 states and territories. 45 of the 52 states is worse, which for the United States, we should not be having these types of things happen to our babies. On to the next slide, infant mortality. On this slide, it's just showing that the Oklahoma infant mortality is 7.1, but you can also see some of the other states. And again, the Midwest regions have the worst rates, of course, than what you're seeing in other states. Okay, next slide. So like preterm birth, we've presented infant mortality by race and ethnicity. And again, we use a 3-year aggregate for all of these states and the US to be able to show data for the most number of states to provide the most stable estimates. So again, the infant mortality rate among Black babies born to Black birthing people is 1.7 times higher than the state rate. And we can see again that the rate of the infant mortality among babies born Black to Black birthing people is 12 per 1,000 live births, or 107% higher than the rate among white birthing people, and it's 126% higher than the rate among Hispanic birthing people in Oklahoma. I don't know about you guys, but I don't like those numbers. That is just way too much, way too high, and we want to see that change. All right, the leading causes of death, of infant death, is this is defined by the World Health Organization, is the disease of injury which initiated the chain of morbid events leading directly to the death, or the circumstances of the accident or violence that produce the fatal injury. We obtain this information from death certificates. Generally, the underlying cause of death is considered the most useful cause from the public health standpoint. The percent of all infant deaths from the 4 leading causes are shown on the state report cards. So you can see the US birth defects is 23.7, and we really kind of mirror, if you will. We're not too far off as far as the statistics from Oklahoma and what the US has. It mirrors, pretty closely until you get down into accidents, which we have a little bit farther discrepancy as far as what the numbers are. Almost a fourth of all infant deaths are attributed to birth defects in Oklahoma, as you can see here. And it's the leading cause in the US. Oklahoma's rate is higher than 23.7 compared to 20.4 in the US. So The percent of deaths attributed to SUID in Oklahoma is 1.5 times higher than the percent of deaths from SUID nationally. And then the next slide. So this just kind of shows you telling the story of, oh, no, now we're on to maternal mortality. And Erin, that would be you coming up.
Okay, great. Thanks, Lori. So a new portion of the report card is maternal mortality. This data focuses on the death from complications of pregnancy or childbirth that occur during pregnancy or within 6 weeks after the pregnancy ends. So this data was derived from the national mortality data or death certificates. A pregnancy flag on the death certificate helps us determine which deaths occurred within 42 days of a pregnancy end. This measure is also used across the world so we can compare our rate to those of other countries. Next slide, please. So the U.S. report card shows rates by race ethnicity for each year from 2018 to 2021. You can see that on the left side of the slide. Note that under the graph, we've also provided 4-year aggregate rates for additional race and ethnicity groups, where 1-year rates are not calculable due to these groups representing less of the overall population. And I know that's really kind of hard to read, but hopefully when you get the real report, you'll be able to see that. And we'll include the U.S. report card when we send that out as well. So each state report card includes an overall 4-year aggregate rate for the same years. On the left, you'll see the maternal mortality measures for the U.S. Oh, sorry, I just went over that. Okay, on the right side, you can see Oklahoma's maternal mortality rate of 30.3 per 100,000 births. That is a 4-year aggregate rate due to suppression criteria. So on the Oklahoma report card, you can see that it's compared to the U.S. 4-year aggregate rate of 23.5 instead of the 2021 rate of 32.9. So since the rate shown on the left is for 2021, while the comparison on the right shows 23.5, the 4-year aggregate, since we're comparing Oklahoma's, we want to use that number when we're looking at Oklahoma compared to the U.S. So next slide. So this is the second report card where we've included the maternal vulnerability index in, as well as in our maternity care desert state reports this year. The MVI is an index used to look at states and counties to see where and why birthing people may be more at risk of poor health outcomes, specifically preterm birth and maternal mortality. The MVI has 6 components: reproductive health care, physical health, mental health and substance use, general health care, socioeconomic determinants, and physical environment. This data is analyzed by Sergo. And this specific data set was made especially for March of Dimes, so it's the most recent data. And you can learn a lot more about maternal vulnerability index by spending time on Sergo's website. It's very interesting, so I recommend that you look that up if you're interested. On the next slide, you can see this year we've included scores for each of the 6 themes, which helps to point out the reasons why women in the state are most vulnerable, or conversely, why they're not vulnerable to poor outcomes. So in Oklahoma, the overall level of maternal vulnerability is very high, and the component that is most attributed to that score is access to reproductive health care. So we can see in the map in the middle that the majority of counties fall in the high and very high ranges. When we look at the chart on the right, we can see the scores for each of the MVI components. So as I mentioned, Oklahoma's leading component is reproductive healthcare access, which has been rated as a 94, dangerously close to the top of the range at 100. So we can see that physical health and mental health substance abuse score also score very high. On the next page, it just kind of shows maternal vulnerability index for the entire United States. Hate to see Oklahoma in those darker colors, the most vulnerable states for women. So then on to our clinical measures. The data for these 2 additional indicators measured on the report card comes from the Nitality files for 2022. So we'll talk about low risk C-sections and inadequate or no prenatal care. So for the next slide, please. So for these clinical measures, while Oklahoma is lower than the U.S. percent for low-risk C-sections and inadequate prenatal care, both of these measures increased in frequency from the previous year's report card in Oklahoma. Over 1/4 of low-risk births, according to the NTSB criteria, are delivered via C-section in Oklahoma. Lower than the U.S. rate of 26.3, but still increased an entire percentage from 24.4. And fewer women in Oklahoma receive inadequate prenatal care compared to the national average of 15.5. This measure unfortunately increased in Oklahoma from 14.2, which is to 14.7. Okay, and then the next slide, I'll talk about policies. So one thing for policy I have to mention is date stamping. So since policy changes all the time, we had to pick an end date for the changes to report. So for all policy measures except for Medicaid extension, the date is September 22nd. It's great that in Oklahoma, we both have Medicaid extension and expansion already in effect. So huge wins for Oklahoma. We're ahead of the game in that. It's really awesome. So next slide. This is also really great. We used data from the National Health Law Project, which had the Doula Medicaid project. So not only did we look at reimbursement from Medicaid, we also looked at if they reimburse up to $1,500. Which is considered a livable wage for doulas. So although we have a check mark with a plus sign would indicate the ultimate goal has been met of that $1,500 reimbursement. So you can kind of see that on the second icon in the legend towards the bottom of the slide. That's what it would look like if we had that $1,500 reimbursement. And in Oklahoma, we have the Central Oklahoma FEMA program and Tulsa FEMA program. So we do a great job with that. Okay, and then next slide. Both the Maternal Mortality Review Committee and Perinatal Quality Collaborative have been in our measures before. And when we're looking at both of these measures, we're looking at their federal funding, specifically if they have CDC funding. So in the work done by March of Dimes, our policy team found that overwhelmingly every single state does things differently. So in order to kind of determine the best way to standardize things by March of Dimes, it's easier to say, okay, federally funding from CDC. So the intent in using CDC funding as ideal was just to determine or the best way to ensure consistency in what each state is doing. So, however, in Oklahoma, although the PQC is not funded by CDC, they report to an NPQC just as other funded states do. Both the PQC and MMRC in Oklahoma are very high functioning despite their lack of federal funding and doing much more work than other states. So although it looks like a negative, it's not a negative of the work being done, but the burden on these programs to do the great work they're doing without the funding from the federal level. Or the CDC. And then our last slide is paid family leave. March of Dimes has been working really hard on paid family leave for a few years now, as it's something that really helps address social determinants, making sure families have a living wage and that they aren't missing out on opportunities when they have to care for somebody or have medical needs of their own. So we did have some positive outcomes last session for state employees to receive 6 weeks, but we're really shooting for the whole state employer paid 12 weeks of paid leave. So hoping to get kind of closer to that. And next slide. We're done. Ready for any questions or comments that people have?
Any
Hey,
questions for Lori and Aaron?
Barbara, I think
Barbara-
you're on mute.
Yeah, her mute is off, but I'm not sure if her mic is
Oh,
connected.
Yeah.
Okay.
Try again, Barbara.
Barbara was having some computer issues this morning, so might give her a second to figure it out.
Or if you want to put your question in the chat. or send it to me, can do that also. Any other questions or comments? I will just note on the committees, just because I feel like we need to. So while we don't receive CDC federal funds, so we do utilize a large amount of federal funds. In fact, the MMRC is 100% federally funded through our Title V, and as well as some funds from also the Maternal Health Innovation from HRSA. And then the PQC or OPQIC also is a subrecipient of federal grant funds through the health department from Title V and Maternal Health Innovation. So while it's not CDC, it would be nice if that was kind of noted, because if HRSA sees that and we've been, I mean, they will wonder why it wasn't recognized that way, probably. But I understand what you're saying, and you're saying specifically for CDC for a specific program that funds those items.
Yeah, and Joyce, that was kind of a point
Thank
of
you.
tension
Can we
between
pause?
me
Can we
and Lori, and
Can we
here's
pause
some,
for just a second?
feedback. Yeah.
Yes, I could say once
Okay.
Barbara unmuted, there was
I
feedback.
think we're good now.
Yeah.
So that was kind of a point of tension between me, Lori, and our policy team, because it really is confusing, and I don't think it's really a great not the best representation, I guess, of what we were trying to get across. I think it was just for ease of our policy team to check, because there's so many states, and trying to compare them all is tough. So that's what we have to kind of advocate for next year. Hopefully, they will change that.
Yeah, I wonder. Oh, it's really echoey. Barbara, are you off mute? I don't know if you are.
I just
She is
muted
now.
her because what's happening, I think when she unmutes, it provides a lot of feedback. So Barbara, whenever you're ready to speak, we'll make sure everybody else is muted.
Go ahead, Barbara, if you want to.
I'm sorry. Can you guys hear me now? Is there a lot
Yes,
of feedback?
we hear you.
Okay. I don't know what's going on. I'm having computer issues today. Yeah, I think I understand why they want to standardize how they recognize PQCs, but I think, like Joyce says, we do receive federal funds. We are not funded by the CDC grant. We did apply for that grant. We were not awarded that grant. And yeah, the first round, we were not allowed to apply for the grant. So yeah, it just shows though that we are doing our work without the support of the CDC, and we still comply with their reporting. So that would be something I would ask the March of Dimes, to ask. They could ask the CDC, who is complying with this reporting. Who do they, I understand why they're saying that, but this is upsetting to me, and it just shows, we do receive a lot of funding support through the health department. Without that, we would not be able to exist. That is our only funding at this time. So it's something that, I would appreciate just how we talked about the methodology with the maternity care deserts, and I was able to talk to them about that, and would love to talk to them about the methodology of this. And in the future, it might be helpful for them to talk to some of the PQCs and the NMPQC and others to get feedback on the methodology. I'm not sure who they did get feedback on before these reports come out.
Yeah, so unfortunately, they don't ask us that work in the state. It's okay, Barbara. They don't ask us working in the state before these are put together. So that would have saved us a lot of headache. But to Barbara's point, Oklahoma really does a great job. I work with the PQC in Missouri, and we model a lot of our stuff around Oklahoma. So hats off to you guys. You're really doing a great job.
And I know you, I'm just going to throw it out there real quick. I know you mentioned that something about the NMPQC. I mean, I wonder if that would be a place to pull who is participating in NMPQC as a list of PQCs. I mean, because we are on the executive committee of NMPQC.
I agree, and I'm going to bring that to our policy team to hopefully use that as a measure next year instead of that CDC funding.
I do think your point though, Erin, about how this can really be used to highlight how we are doing all of this work without any funding. And maybe that is going to be something we can see as a bright spot in this report. I don't know, you at least maybe try to use it, turn it positive in some way, because we do all of this and not without a lack of trying. I think it might feel a little bit like salt in the wound because we put so much effort into trying to get all of this funding, and we are just denied over and over again. So sometimes when we see reports like this, we're like, I wish, it sucks because we're just working so hard without a lot of help.
So there is a question in the chat about curiosity on what is the reason behind Oklahoma not being awarded the CDC grant?
I don't know why I'm having this trouble with my microphone. Can you guys hear me?
Yes, we can.
I'm sorry about the echo. I had to join by my phone, but I'm signed off on that, so I don't know why it's echoing. But well, we have applied for the grants. We applied with just our team. We had never applied for a federal grant before, and so it's our team working on that. We don't have experience in writing applications for grants. Our feedback has been pretty good onto our proposal just with the evaluation piece. Other states have grant writing teams that apply for their, that do all their applications for these grants. So I think that's why, obviously ours wasn't as strong as other states in their opinion, but, that's my only reason to know why is, we're trying to write these grant applications with just our team, and we're not really experienced in this and don't receive assistance.
Any other questions or comments for Lori and Erin? Great job, by the way, ladies. And thank you for listening to us. So yeah,
and I have to apologize. Like some of our graphics were a mess, and tables, things like that, because those are usually prepared for us, but they wouldn't release those ahead of time. So I had to kind of pull them from multiple places and stick them together. So thank you for bearing with us.
And just before we move forward, there's been some comments and different things in the chat about the data and our state support around indicators of the report card. Lori and Erin, I'll make sure I capture all of those and send those to you, so you'll at least have that information to share with the upper administration of March of Dimes.
That would be great. So, Erin and I are your biggest advocates in Oklahoma to make sure this data is correct and that we're recognized for the things that we're doing. So I can't stress enough how we lobbied and tried to get that changed before the release was submitted. But they were wanting to be consistent with how the data was derived, and I understand that, but we certainly are going to advocate for that to not be that way next year, because we need to be recognized, and Barbara and her team need to be recognized in the MMRC for the good work that you're doing. And I feel like that doesn't recognize you guys. So we are going to try to see if we can get that changed.
We appreciate that. And you
Thanks,
know,
Lori.
you need any of us to support you. I think Barbara, you're off there. If we need,
We
that we're
appreciate
there.
you, Lori and Erin. Yeah.
Okay, I think we're back. Well, just say thank you. And we appreciate all that you do and you're wonderful partners, and we'll continue to work together with you in this regard. And again, like I said, thank you. And everybody remember, wear your purple on Friday for World Prematurity Awareness Day. Also be the Oklahoma Perinatal Quality Improvement Collaborative Summit, which hopefully many of you will be there, and we'll be able to discuss many of these items further. All right, well, moving forward to our updates. So these are our work group year-end updates, and I believe we have breastfeeding up first. Amanda, are you speaking, or Becky? Or
I
Adriana?
think actually Jacqueline is covering today.
Jacqueline is covering today. Okay.
Yes, and I'm here.
Wonderful. Go ahead, Jacqueline.
Can you guys hear me?
Yes.
Oh, okay, good. Sorry, I said I was muted when I unmuted. Okay, perfect. Okay. So yes, so I am, for those that don't know me, my name is Jacqueline Huxford, and I'm with the Oklahoma Breastfeeding Resource Center. And I also manage the breastfeeding hotline, which is a big piece of the a big part of what I do. So just a few kind of updates. We are still looking for a IBCLC for the OU Health Outpatient Clinic. So if you know of anyone that is looking for a position, one thing to be noted is that they do not have to have any additional credentials. They do not have to be a registered dietitian or a registered nurse. Obviously, if they have that, that's fine. But if they are an IBCLC seeking employment, it's a full-time position. So please reach out and apply. If they have any questions, they can email me directly and I can point them in the right direction. I'm going to go over our maternal care and best practices scores and rankings. And then we are scheduling for 2024. So we have 2 different courses, actually 3 that we offer. So we have a Making Breastfeeding Easy, Breastfeeding Basics and Beyond, which is one is a 2-day class, one is a 1-day class. And then we also have a new one that we've done a few times, which is a Making Breastfeeding Easier in the NICU. So if you are interested in one of those trainings, please reach out to us and we'll get you scheduled. And then a little bit about some legislation that's going on. The family care item tax exemption, it recently passed. So we're very excited for that. Thank you, COBA. They are our driving force behind any breastfeeding laws that are passed here in the state of Oklahoma. So we applaud their efforts. And then the law exempts breast milk, pumping products, diapers, period products, and maternity clothing. Okay, next slide. I froze. Oh, there it is. Okay, and I apologize. I'm having all kinds of technical issues this morning. My computer sound stopped. I couldn't get logged back in, so now I'm on my cell phone. So if y'all can't hear me or something, please let me know. Okay, so I'd already mentioned this, that we are scheduling for 2024. We've had a very busy 2023. Actually, Becky is teaching today. So we're very, very busy, which is good. Okay, next slide. I'm sorry, I'm going to try to join on my computer again. It would not let me in. Oh, there it went. Okay, I apologize. Okay, so this is the data that was released in from babies born in 2020. And it was, I'm sorry, my daughter is trying to break into my office. So this was the newest data that was released for Oklahoma, and then of course for the US national ranking. So we, you can see our ranking right there. So sadly, we did go down in a few rankings. So not to add to the depressing tone of Oklahoma's stats. But we do have that there. So they're kind of to highlight the ranking for breastfed at 6 months, and then the exclusive breastfeeding through 3 months and 6 months all moved down in rankings. And then next slide. Okay. And then these are our MPINK scores for Oklahoma. So these are done about every 2 years. The CDC initiates all eligible hospitals across the country to complete this. And it is self-reported, so I do want to kind of note that, but you can kind of see our score there. So we were a little bit above the national average, which is good. But we do have some work to be done, and you can kind of see that I do believe on the next slide. Kamisha, if you'll go to the next slide, what I wanted to touch on. Okay, sorry, my technical issues today. So this is the next slide. So this is kind of what I wanted to touch on, kind of where we have a little bit of discrepancy on the rooming in. We're doing great with okay, so yes, the rooming in, we're doing well there. But for whatever reason, you can see the rooming in's 93%, but then for the routine exams and procedures, we're at 48%. So they're still not doing those in the patient room with the family. So just a little bit of work to be done there. And then the breastfeeding newborns receiving formula, 48%. So that's, less than half, which is good, but still needs to be a little bit better. And then hospitals that do not perform routine blood glucose monitoring on newborns at risk, we're doing pretty good there, 90%. Okay, next slide. I don't know if I lost connection again here.
We can hear
You
you
guys can
again
still
now.
hear me. We can go to the next slide. I think I've got one more slide. Okay.
I'm
there we
currently
go.
on the Ban the Bag program.
Yes. Okay. So this is the most current list for Oklahoma hospitals, which I'm sure most everyone is aware that we have now 44 birthing hospitals in the state of Oklahoma. And then this is the list of all the ones that are reporting that they are banning the bag. So this is a good list. Obviously, we wish that all 44 hospitals were listed on this list, but we will definitely applaud the efforts that are being made for these hospitals that are on this list. And if there is someone that is banning the bag and they are not listed here, please let us know. But we're happy with 56%.
Great. Thank you, Jacqueline. That's wonderful
And then,
news.
thank you. I apologize for my technical issues this morning. Like I said, my computer, the sound went off and then it wouldn't let me log back in, but thank goodness for cell phones. And I do wanted to note that registration for OBRC's annual summit will be open in January, and the date is March 1st, which is a Friday. And we have our speakers confirmed. We have Montrese McNeil Ransom, and we also have Marsha Walker. And our focus this year is on communities and communication. So we're really getting excited for our summit. So if you have any questions, just let us know.
Well, very good and great information and some really good news there in relation to numbers. So thank you for sharing. And it looks
Hey,
like
Joyce.
Heidi has her hand up. Yes, Heidi.
Oh, yeah. Hi, everyone. I just wanted to clarify and make a correction. That law is a Texas law that passed in Texas. We are hopeful to propose similar legislation here in Oklahoma in 2024, but that is not a law that passed in Oklahoma.
Right. It's in Texas. And you're modeling it after.
Correct. Thank you.
You're welcome. Thank you. Okay. Next, we have injury prevention.
Good morning, everyone. We just have a few updates. We met last month and kind of went through our website and talked about edits that we need because it's been a few years since we've kind of tidied up and edited website points and made sure that all the links work and all that good stuff. Our meeting dates have been set for the next year and sent out. If you'd like to participate, please just shoot me a message. We'd love to have you. We are still recruiting for a co-lead opportunity. As you know, Lisa Rhodes retired, and so we, we're open and we're a fun group. So come on over. We're waiting still to hear about the contract for the hospital-based abusive head trauma prevention. So hopefully we'll have all that stuff worked out. You know, sometimes the state takes a little time to get contracts through and when there's a bid process. And then the grandparent toolkit, that work group also met last month. We heard from the various work groups. Things are in different stages of completion. Some groups are closer to the finish line than others, but we're hoping for a December completion date of all the materials, and then we'll be able to work with our comms team on recording and getting the information out. So for those of you on this call who've been helping with that, thank you very much. We're excited about the potential for the toolkit. It'll be some presentations and videos and resources that can be used for grandparents who are taking care of their children in any kind of capacity across the state. And I think that's it.
Great. Thank you, Alicia. Any questions? Okay, after each one, if anybody has any questions, please jump in, or you can raise your hand either way and we'll notice you. All right, so the next group we have up is infant safe sleep. James?
Sorry, I'm trying to figure out how to find my shares. There we go. Everybody see that, hopefully?
Yes.
Okay. So as I think most of you guys probably know, October is SIDS, or what I like to say actually now is Infant Safe Sleep Awareness Month. I think SIDS is just too limiting. It's not broad enough. So I try to keep saying that. We've had some great efforts, I think, put forth on social media to raise awareness. Our communications team put out some posts on social media, Twitter, I was going to say Twitter, I'm going to call it X, Facebook, highlighting our infant safe sleep booklet, which I'm pretty proud of. I think it's been great to share that, show folks the elements that are in there that we talked about promoting new guidelines. I also was lucky enough to have a couple interviews. One of those was with Channel 9. That was a live interview. We talked about what are the risks, how we can indicate protective factors, things like that. I'm always happy to do that. Not really happy to do it. It makes me nervous, but I'm glad to get the word out, basically, put it that way. For the group, this isn't new, but I hadn't shared it with the broader Preparing for a Lifetime Coalition. So I wanted to highlight HQ put out this results of their listening session several months ago. And I just wanted to highlight some of the stuff that they had in here. Basically had a poll of focus groups for a lot of allied health professionals, whether it's doulas, mental health clinicians, nursing, looked at some of the responses they got when it comes to education around safe sleep and breastfeeding. And I just thought some of these things were really interesting. Especially looking at some of these folks have said things I've said for a while, which is that, when we see health professionals, whether it's nursing, social work, whatever, talk about safe sleep education, a lot of them have been around for a while, of course, are used to, well, this is how we used to do it, and we need to make sure that they get the word out because we know, as I say pretty often, nursing is especially, it's pretty much the most trusted profession out there. So it's also, we look at the bottom quote, I think pretty telling that there's a conversation about making sure that we do this education, which I keep trying to get better at each time I do this, that we're not using guilt or shame. We're trying to be as positive as possible, although of course we've got to be realistic with risks, so it's a balancing act as always. Of course, talking about people trying to breastfeed and 2 in the morning, you're exhausted, you're doing the best you can. Sometimes things happen where you may accidentally do that. So again, giving parents strategies, as I say often, gotta give them tools for how to do this safely. I just say, don't go sleep. Talk about making sure you have a good support system, making sure that you've got folks you can call at 2 in the morning just to say, please talk to me, keep me up, help me make sure I get this kiddo back in the sleep space. Listen to podcasts, watch trashy TV, whatever you got to do. Right? So we don't have, because I'm co-lead on this group and perinatal mental health, I'm just going to transition that way. So talking about updates on that side, one of the things that we noticed, well, I noticed for sure, whenever I looked at our booklet, our Return Mental Health Matters booklet, I think it's great and it's done a great job, but there is some information that we needed to update. We have our partnership with OPQSC and the link they have on their page for the resource map for clinicians who are trained in perinatal mental health, but it wasn't in the booklet. And so I thought, well, that's an oversight to fix. Also included in this new version, the link to the PSI support meeting. So I thought that was also an important component. So we've got that in the new version. All the ones we printed now, the new digital version reflects that. Also on the other piece of this that's updated, I don't know why, yeah, I did highlight it. There you go. So I have, when these first were made, the maternal mental health hotline didn't exist. So we couldn't put it on there because it wasn't a thing yet. But when we did the reprinting recently, I thought, we've got to make sure that's on there. So that's included now. Finally, making sure that when it comes to resources, I talk in there, there's the group put this together about having a postpartum plan, but we didn't actually have a way to get folks there. So having a QR code that you can scan directly links to that, I thought was really important. So that's there too. Recently, of course, back in October, this is the 4th Climb Out of the Darkness. It's actually the 3rd in person. Of course, 1 year is virtual for COVID, and really a great success. 100 participants, which is the most in person it's ever been. Great turnout. And of course, on the fundraising portion, they raised $5,000. A big chunk of that will come back to the Oklahoma PSI chapter. So that's pretty exciting. Last thing that I'm going to share is this study that came out I thought was really interesting. It talks about the fact that, not only pretty often, of course, we talk about mom and postpartum depression, not as often about dad. And this looked at the link between fathers experiencing postpartum depression and ACE scores before finding. So looking at almost not quite 2,000 father-child dyads in this study cohort, most of those who ended up having postpartum depression in the first year of life, we saw big jumps in the ACE scores of these kiddos, 2x actually experiences. To have 3 or more of those adverse childhood experiences. So really just, I think, underscores the need to do more outreach to dads. Make sure that whether the dad and the mom are together or not, that both parents are, as healthy as they can be before it comes. That's all for me today.
All right, thank you, James, for sharing that information and those updates. Appreciate it. All right, and next we have preconception, interconception. Jill?
Good morning. We'll get up to our slide in just a second here, but I didn't put a item on my slide that says looking for a co-lead for this work group. But since Alicia mentioned it, I'll state too that I'm continuing to look for someone who wants to share the responsibilities for leading the preconception, interconception work group, because I'm sure there's probably some things that I'm missing. But for the moment, we still have a lot of things that are going on. So I'll share with you that our work group is helping to promote the Medicaid coverage of postpartum care for up to 1 year. And we'd had some meetings recently with staff from the Healthcare Authority to find out what they're doing to send out information to let people know that they're going to continue to have coverage for up to a year. And recently we've heard about some people that either think they lost coverage or lost coverage. And so we've redirected them back to the Healthcare Authority to make sure that their coverage is still in effect and that they understand their coverage is still in effect. We're also continuing to work with the Healthcare Authority on the Sooner Plan option, raising the eligibility income to 205%. As far as I know, implementation is still expected in January of 2024. And if you're not familiar with this is just a plan that covers family planning services. We've had it for quite a while, but they were going to sunset it with Medicaid expansion. And then we realized that there's still a need for access to reproductive health services, which I think they brought out in the slides earlier, that's an area that we're not doing so well in Oklahoma. So extending Sooner Plan will help provide access to family planning services for those that don't qualify for full Medicaid benefits. We're continuing to support the Focus Forward trainings, which is trainings on LARC insertions for healthcare providers. The last one for this year is scheduled in Tahlequah on December 9th, excuse me. And then there's 2 more scheduled for 2024 at this point in time. That date is not right. The one in OKC, sorry, I'm have to look that back up. I don't think that the date for OKC is correct. But there's one in OKC and one in Tulsa scheduled for the spring. And then yesterday we had our meeting with Cox and found out that our preconception and maternal mortality messages that we have out on our social media and streaming services are still doing fabulous. We're getting a lot of traffic. People are not only looking at them, but clicking on them for more information. And so if you haven't seen them, the health department is promoting it as well as Cox. And they're under the title of Women's Health and Maternal Mortality. And then we have our aspirin therapy campaign too, which has gotten a fabulous response. And a lot of people have watched the videos. I apologize, I made this slide before the meeting last evening, so I don't have the exact numbers, but everyone was impressed by the response that we're getting, especially from the aspirin therapy videos that people are clicking on. So we're getting the word out. Let's see, so our state-funded family planning program is still progressing. We're still providing the same level of services. And so we're happy to report that in the county health departments, we still have access to reproductive health services at the same level as we did when we had the Title X grant. And then as far as our partnership on fatherhood projects, I just want to again promote the fact, we talked about it before on this meeting, but James created a toolkit for fathers. And that didn't fall within what he reported today, but we want to just mention that he did create that. And if you're interested in that information, you can get in touch with either James or I, and we can get you some copies of that. He did an excellent job, and so we want to give him credit and promote that.
I can drop it in the chat, Jill.
Okay, that'd be great. He'll drop it in the chat, a link to that document. We did share some of those recently with people who attended the Moms Tour that was held at the YMCA last weekend. We sent some copies of the booklet because I had a Dad's Den there. So I didn't go. We sent it with another representative from the agency. So I'm not sure what the uptake was, but I do know that we promoted it there for you, James. And then our maternal health innovation grant projects are continuing to do great. We have the STAR Clinic that provides prenatal care for individuals with substance abuse and mental health disorders. And we still have great statistics from that showing that people are getting into treatment and that they're getting the services they need to be able to take their babies home with them. And also to get into treatment when it's needed. Our Cherokee Nation project with the maternal fetal medicine clinic is going great. Their appointment slots are filled up every single clinic. They have one clinic in person and one telehealth clinic. And absolutely, if they had more money and more staff, could expand that. So that's definitely a needed service there. Southern Plains Tribal Health Board is working on an Indigenous toolkit, which mimics the Preparing for a Lifetime toolkit. If you've seen that, they're just editing it so that it's more geared to colors and themes and things that resonate with our Indigenous population. And they're also doing a lot of social media messaging and streaming about the monthly health observances that we're promoting. They're also promoting, but they're also editing those so they resonate with their population. We're excited as far as prenatal care in our county health departments. We're excited to say that in October, we added District 3 in our list of clinics that are providing prenatal care, and they're doing that in Creek County. And I already have, I know a couple of clients because we discussed them with Dr. Gold's group at OU on our meeting last week. So we're excited to say we have maternity clinics in District 3, 5, 6, 7, 8, and 9. So yay, we're getting there. Our access to care work group doesn't have anything new to report because we're going to move forward and work with Kamisha's group. But I can say that our last preconception meeting, we discussed the fact that we are looking for information on doulas that are already out there. We're trying to create a survey and a list to see what resources are actually available. And we did pick up a couple of links to some doulas that our staff know about. So if you know of any doulas, we're still working towards creating a picture of what the landscape resources currently are and where the gaps in services are for doulas and midwives. And then our work group is going to work with Aisha on a PRAMS product that we're working on unintended pregnancies that wasn't ready for review yet, but work group is ready to provide some input on that, and still supporting activities from the syphilis task force. And I know that this is an example of how things all kind of come together, but the Southern Plains Tribal Health Board held a testing clinic in Anadarko recently and identified a pregnant woman who has syphilis that now is being seen at the health department, and we're linking her with prenatal care services. So that's an example of how we kind of all partner together. We're always looking for community events where we can share preconception, interconception messages, and our next meeting will be in January on the 11th at 3 p.m.
Thank you, Jill, for sharing those highlights. Appreciate it. All right, I think next we have our prematurity work group. I know you've heard from some of the work group earlier with the March of Dimes presentation, but I believe they have some additional items they may want to share. So Barbara, Lori. Barbara.
I don't know if Barbara, if she's still
Yeah,
having problems. The biggest thing is that we're working on the low dose aspirin campaign, really having a lot of traction in that campaign. And I know Barbara could probably address this a little better than me. Melissa Ward is on her team, is working on this, and has been doing amazing work to put the whole toolkit together and get the message out about taking low dose aspirin during pregnancy to prevent preeclampsia. And I think she's been getting social media hits over 100,000 and just different messaging that we have out there. And I know we're doing this in conjunction with what the state health department is doing, some PSAs and some marketing around this campaign as well. And so I know that this is going to be presented at the conference on Friday in regards to the low dose aspirin campaign and what we're doing. So I know that there's going to be more in-depth details about that, but lots of great information, lots of great progress in regards to this on helping try to reduce the preterm birth rate by taking low dose aspirin. So really that's what our committee has been focusing on how we can get the word out to everyone. How can we also be able to see statistics and track who's taking low dose aspirin, making sure the providers are giving that as an option, and that we can track who are taking this, so we have some parameters and some statistics around this to be able to report on this making a difference. So I know that we just had a committee meeting yesterday and talked about a lot of the progress, but again, I know that a lot of this is going to be addressed and presented on at the conference on Friday. But lots of good progress with this, lots of good information. And again, Melissa Ward has been doing an amazing job getting this information out. And I will say, Melissa did attend one of our March of Dimes board meetings and presented on this to our board. So I know that she's always looking for opportunities to get the word out and present on this information. So if this is something that you would want her to attend one of your meetings and present on this information, I know she'd be more than happy to do that. Here I am committing her to work, but I know that she's looking for opportunities to get this message out. It's all about awareness, and this is a big part of what we're doing in the initial stages. And Joyce, you might want to mention about the PSAs that the state health department is doing and the progress around that too.
Are you trying to speak, Barbara? Before
I don't know if I'm still echoing. Melissa, she is going to provide more information at the summit on Friday, but if you want to put your contact information in the chat, Melissa, because part of this is a public awareness campaign about aspirin. So even if you are not a provider that would prescribe aspirin, low dose aspirin during pregnancy, we do have some posters and things like that to share that can help you create the awareness that most women should take low-dose aspirin during pregnancy. So we want to get the word out there that they should ask their provider about it. And it needs to start ideally between 12 to 16 weeks. So just want to make sure people are aware of that. And she will provide more information on Friday at our summit.
Very good. Yes, she's done a magnificent job, and we love having Melissa as part of our state team in this. And like I said, Barbara said, you'll hear more from her at the Oklahoma Perinatal Quality Improvement Collaborative Summit on the 17th. So stay tuned. And also in relation, I talked about the campaign, and it's been referenced a couple times. So yes, we do have a strong campaign running in relation to the low-dose aspirin or aspirin therapy. And it is, as Jill referenced earlier, it's got a tremendous response. I know both from what we're putting out and also from what OPQIC and others are putting out. So we're getting the message out. People are reading it. They're interested. We're hoping that will take, because I think it's been about 70% of the population of our pregnant population would appear to qualify for this intervention based upon the risk factors. So anyway, it's one we really want to get out and are hoping will make a difference in preterm births and keep bringing that back down to where it should be, which of course we'd like it at 0. It's never going to be there, but it can definitely be significantly lower. And we want to protect both our moms and our babies and get that message out and save lives and reduce morbidity also. So I think that brings us to the end of our meeting. We do have some acknowledgements for months that are also coming up. We talked about November, but for December, since we won't see you again until February, Safe Toys and Gifts. There will be information coming out, campaigns in relation to that, and wanting to keep our children and babies happy, but also safe in relation to toys and gifts around the holidays. And then for January, very important, National Birth Defects Prevention. Definitely be putting out information in regard to that. I want to continue to keep birth defects down. That's still the #1. And then National Folic Acid Awareness Week, which goes along with that, but it has a specific week for 6 through 14, recognizing the difference that folic acid can make in reducing those birth defects. So again, stay tuned for the awareness items that are out, specifically this month in relation to prematurity awareness and low-dose aspirin, and support those efforts however you can and help us spread those messages throughout the state, get those to those who need it. I think as far as quarterly partnership meetings, so for next year, this is your list. That'll also, I think, went out in the group of information that was sent out, and will go out again for the meeting that goes out at the end of the meeting. Just remember, we will wait to send this until the March of Dimes items are released, which will be tomorrow, because it is currently embargoed until tomorrow. So we can't release any of that information until that time. Anybody else have anything that they want to, announcements they want to make before we end? Comments?
So Joyce, I just want to add, as we prepare for our 2024 year, I want to say that we will be celebrating 15 years of this initiative. Preparing for a lifetime is everyone's responsibility. So be on the lookout for additional information that will be coming out. Our teams and our work groups will be talking about different programs or different release that we're going to do to celebrate and honor the 15 years of impact that we had in the state of Oklahoma. So just be on the lookout for it. I'm excited that we're hitting the 15-year mark on this initiative.
Yes, thank you, Kamisha, for bringing that forward. And we are very excited. You've made a difference in what you've done. We've seen it. in the numbers and in the people's and babies' lives. So thank you and have a wonderful rest of the day and happy holidays.